Hello, everyone. I'm just letting some more people in, and we're going to get started in a minute. Hopefully quicker than a minute because we're a little late. Sorry about the link mishap for anyone that got kind of stuck with that. Hopefully everything's working now. And hopefully everyone can see my screen. Hello, everyone. My name is Kira. I will be your host for today. We have a few people that are also volunteers. If you have any questions for them, you're more than likely to, you can private message them. You can message in the chat. You can ask any questions you'd like. I know that Dr. Littenberg is going to be answering questions throughout. I just wanted to say thank you guys for joining. This is Pre-Health Shadowing. We are an international, student-led, women-led, minority-led nonprofit for medical advancement. We are changing that, so maybe we'll be a little bit different as well. We do have closed captioning for those who need the closed captioning. That is through Zoom, so sometimes that's a little finicky. If you have any more ideas on how we could be more accessible or a little better than the Zoom abilities, I'm sure that they are improving every day. You can email us at info@prehealthshadowing with those ideas or any questions you have regarding this session. We can also provide you with a transcript or any kind of needs that you need to be met that we can help you with. We're more than happy to help you with. And you can add us as a contact so we stay out of your spam, because sometimes even replies go to spam. So if you want to stay in our loop, I am the marketing department head. If you guys have any questions, and I monitor a lot of our social media. So if you have any questions regarding that, I'm more than happy to answer those as well. We do have Instagram, we do have TikTok, we have X, which is Twitter, we have Facebook, and we have YouTube. That's not on this list. Should probably be added to this list. And then we have an email list that you can join if you email info@prehealthshadowing.com. And again, add us to your list so we're not spamming you. I do like to always ask everyone where they're from, because sometimes we get some international people, sometimes we get a lot of East Coasters, West Coasters. We have a lot of people scattered all over the place. I know that I'm in Los Angeles, California, and I have a few people on my team that I think are also relatively local. So if you want to post that in the chat, you can. If not, then you're more than welcome to stay quiet. I know that some people aren't. Ooh, there's a Toronto, Canada person. My family is from that kind of area. New York, Las Vegas, Nevada, Burlington, Vermont, of course, Dr. Lindbergh. San Jose. Wow, we have someone from Seoul, South Korea. Hopefully I said that right. I always mess up on that. New Jersey. Villanova, Pennsylvania. I don't even know where that is. Another Los Angeles, New York, San Francisco. I love San Francisco, although I don't think I could drive there. Ooh, we have someone from Jamaica. Welcome. A lot of different time zones. I always think it's crazy that people can still make all their times in the United States and around the world. So we're going to keep moving on. Sorry if I missed your location and you didn't get the shout out, but we're going to keep going. So if you're interested in being a part of our pre-health shadowing world, you can be a volunteer. Volunteers are 100% remote. We work with you on your schedule, so it's completely flexible. If you want to join at 2 to 3 in the morning and you want to do an hour's work every day, you're more than welcome to do that. We allow any schedule you want, as long as you're putting in the time towards a project that you sign up for. We're very happy to have you. I'm always welcoming people who want to donate some time. If you want a heftier role, we do have our leadership team. Our leadership team is an actual position within our nonprofit. And so you would get a title with this, and it's varies on the type of work that you want to do, but it is a minimum of 5-hour commitment a week. And that's also 100% remote. Most of our positions are. There are some very rarely temporary positions that are in person, random places that we have. We do have leadership roles in the IT department, grants, fundraising, recruitment. And if you read at the bottom, it says "and more." That's for you to decide. You can make a position within our departments, depending on if you feel there's not a place for you and you have a skill that needs to be shown on our applications or our websites. You're more than welcome to kind of create your own position or make a position that fits more your style of things. So that would still be an interview, still an application. It's not as easy as you might think it is. You can just go to the website link below. That's just as it's our website /contact/join our team separated by dashes. It's pretty easy to remember, but you can also just go play around with our website and I'm sure you would find it. So if you're a high school student, we do get some high school students occasionally here and there. I always like seeing high school students because you are fresh and easy. I am non-traditional, so I went a very odd route to my med school path, but high schoolers seem to know what they're doing. Maybe, hopefully, fingers crossed. So if you are, oh, someone just drew on my slide. I didn't even know you could do that. You can join our high school training program. We do offer a leadership for pre-college learners as well. And that training program's on our website. You can go and see more details. You can ask questions about it. You can see how it works. It's more so establishing an organization or a club on your, I think you guys can see my mouse too, on your campus. And so you can start a group there and then you can list that on your CV or your transcript, not your transcript, your resume. And that's a great way of showing that you're dedicated to the medical field. So we do have diversity panels occasionally here and there. If you do know someone that you think is inspiring towards kind of talking about diversity in anything, LGBTQI+, sexism, any kind of racism in medicine, any of those kind of topics, then you can also nominate them. You can email them to info@prehealthshadowing.com and you can just say, hey, I would love to nominate my teacher or my professor, and they do not need to be a PhD for that. They just need to be professional. If you can, we always love donations. We run pretty much solely on donations and partnerships. And so if we want to stay free and accessible to everyone, I know we have a lot of high school students in here that can't afford a lot of things, and a lot of stuff tends to be expensive in the medical world. So we do run off of time and donations. So if you can't donate money, you can always donate time and be a volunteer with our organization. Just scan the QR code right there. Hopefully my face is not blocking the QR code. Uh, and then you're more than welcome to share this around as well if you want to share that with a family member that you think can donate, even if it's a few dollars, $5, $10, a lot of you guys can, if you donate $1, can go a long way in our organization. So our last but not least thing is if you do have any questions, you can just type those straight into the chat. We do have a Q&A towards the end of this, maybe about 20 minutes, maybe about 15, depends on how long Littenberg wants to talk. Some of our professionals talk towards the end and they answer questions throughout. Dr. Littenberg said that he would, if he notices your question, he would answer your question throughout his PowerPoint. And so you guys can more than welcome to ask those. They will not get skipped. I do keep track of those and my team will be writing those down. So don't worry that your question will be amongst the kerfuffle of all the other replies. So take good notes. We do have a post shadowing assessment, a little mini quiz at the end of this, and I will be describing how that works and how you can earn your certificate. If you guys have any questions about that, you can also ask them towards the end as well. And so my last thing, if you guys can turn your cameras on, it's always nice seeing everyone's faces. If you're not, no worries. If you don't want to show your face, you don't have to. But if you do, I always love seeing more faces than less faces. And so I just want to say thank you so much for attending. I see a face. And now it's Dr. Littenberg's time to share, and I'll kind of get out of here, out of everyone's hair.
All righty, let's see. I am going to turn on this, and now I should be able to share it, is the theory. Ah, there's the share button, hiding in plain sight. Okay. So, my name is Ben Littenberg. I'm an internist, a physician. I practiced primary care internal medicine for 40-something years and retired a couple of years ago after some health problems. But most of my career was actually spent in research, as well as taking care of adults, and doing some teaching in the hospital and in the clinic. Today I wanted to tell you, my favorite thing is clinical research, and sometimes now called translational research. How do you take an idea and move it from a glimmer through the science and into something that can really be used to take care of patients? And it's a relatively new development in healthcare. It was really only about 150, 200 years ago that we even started applying much science to healthcare at all. There wasn't much science to apply. Biology was pretty crude. Psychology was even cruder. And it was only in the 19th century that we started even getting some basic tools. We still have one or two drugs that we still use left over from the 19th century, but not many, and one or two surgeries. But so most of the science in healthcare is super modern. But this one goes back a little over 100 years. And the science behind it is not very complicated. And the impact it had on the world is massive. So I wanted to tell you about how insulin came to be. Um, this is a picture of insulin, at least the insulin molecule, the way a molecular biologist might think of it. It's a kind of schematic cartoon of insulin. Now, my button isn't doing anything. There we go. So these are other pictures of insulin. We've got some recent vials of insulin and a modern insulin and syringe to inject it. And then that bottle in the upper right-hand corner is one of the original bottles of insulin that was made back in 1922, really just the first product to be made with insulin. And uh, if you ever saw a movie from the 40s or 50s of the heroic bush pilot flying the serum through the storm to save the child, it was insulin. That was the serum they were delivering. It was a tremendous phenomenon. It just changed the world. Okay, so here's our agenda. How was insulin discovered? What was the role of science, and who asked the questions and the right questions? How did they answer them? What were their barriers, and how did they overcome those barriers? And what knowledge, skills, and attitude did they bring to the picture? We'll talk some about what does insulin do? What does it do to patients? What does it do to other people? What does it do to the disease itself, diabetes? And it's been a kind of long and winding road. A little bit about how it's made and distributed and paid for. And then I wanted to talk about the downsides. This is possibly the greatest life-saving drug ever invented, and yet it's got some pretty nasty downsides. So there is no free lunch, and we'll talk about that. The blue circle, everybody knows what the pink ribbon is, right? For breast cancer, and there's a blue ribbon, and there's like 15 or 20 different color-coded ribbons now for different cancers. Well, the Diabetes Association wanted their own super simple logo. So they came up with the blue circle, which no one seems to ever recognize. It is a complete dud of a logo. So I just thought it's another failure. What can I tell you? Okay, let's go back a little ways to the first century. Here's a guy writing from, I think, Greece. Life with diabetes is short, disgusting, and painful. Well, that's a cheery assessment. In the 19th century, we've got this description from a guy who wrote a history about insulin. Drowsiness, semi-consciousness, the lungs heave desperately to expel carbon dioxide. The diabetic took huge gasps of air to try to increase his capacity. It's air hunger. We still call it air hunger. The gasping and sighing and the sweet smell lingered on until they slipped into a deep diabetic coma. At this point, the family could make arrangements with the undertaker because death would be just a few hours to end the suffering. And this was, I mean, diabetes was an absolute death sentence, and it was almost entirely children. So this is type 1 juvenile onset diabetes. Type 2 diabetes was essentially unheard of until we had insulin for decades. So this was all about children who would suddenly start losing weight and start making huge amounts of urine and would, over the course of weeks and months, waste away, and then they would start getting drowsy and they would die. And it was common. Until 1851, the only way to diagnose it was to taste the urine because the diabetics were not able to control their blood sugar. So their blood sugars would go up super high, and it would wind up so high it would spill over the kidneys, as we call that spilling. They would be filtered by the kidneys and show up in the urine, and the urine would actually get very sweet. And so to screen for diabetes or test for diabetes, you have to taste the urine. And this was not a favorite maneuver. Physicians didn't really like it for some reason. And so, although sometimes it's written here, the physician in charge would sometimes call upon the house officer, the resident, the intern, to apply the test. And so I got a picture of an intern testing for diabetes. And the trick I was told was you dip a finger in and you lick it. And then an older physician once told me the real trick is you dip one finger in and you lick the other finger. So diabetes humor. Okay, around the late 19th century, urine tests got quite available to check for glucose in the urine. And so diabetes shows up as a diagnosis more and more after around 1885. By 1923, you could get a penny a test to do it. Now, a penny was a lot of money in 1923, but still, that was pretty cheap. And so it got to be you could actually manage the diabetes by testing people's urines. Okay, now a little biology. The pancreas. Boy, if you guys were in the room with me, I would ask, does anybody know what the pancreas is? And I can only see two of you, and neither of you two are answering. Is there anybody who has an answer here? Yes, Miss Abby.
So, hi, Dr. Littenberg. The pancreas, it releases some enzymes to help with digesting food from the stomach.
It does.
I think it releases, what's it called? Does it release insulin
It does. It releases two sets of hormones. One
and
are
glucagon?
there's two sets. There's the
Okay,
digestive enzymes, and what it does is my arrow showing up on your screen here?
yes.
So what it does is the pancreas is this green cartoon here, and it releases right into the stomach or just south of the stomach into the intestine. It releases hormones that break up food. So they're the digestive enzymes. But it also, just coincidentally, releases into the blood a whole nother set of enzymes that have really nothing to do with the stomach. And it's really insulin is the main thing it releases there. So
Okay.
and here's our anatomy. The stomach, the pancreas is tucked in right under the stomach and right deep in the middle of the belly. So if you're ever looking for a pancreas, you could find one there. Here's a picture. This is what the pancreas looked like in 1918. It still looks roughly like that, although they're often in color. This was from Gray's Anatomy, the famous textbook. It was actually a book before it was a TV show. And the book is the leading textbook of anatomy for 100 years. And so here you can see the pancreas and the ducts and the ducts that feed the digestive enzymes into my favorite organ, the ampulla of Vata. I just like it because it's got a silly name. And it's basically a little gateway that lets the hormones, the enzymes out of the pancreas and into the intestine. Okay, here is our first hero. His name is Paul Langerhans. He was a medical student, and in 1869 he wrote his thesis, Contributions to the Microscopic Anatomy of the Pancreas, and he refers to islands of clear cells throughout the gland. And when he put them under the microscope, they had a different appearance than the rest of the glands. He thought they were lymph nodes. He also described some cells in the skin that are also called Langerhans cells. He thought they were nerves. They're not, and he was wrong in both counts. This guy got everything wrong, and yet two major structures in the body are named after him. So he really was really good at being, a scientific self-promoter. Okay. Let's see. Here is what the islets of Langerhans look like, and these big loops are cells that are secreting the intestinal digestive juices, and they're called the alveoli. But then in the middle, there's these islands. This is an island of cells that aren't as dark, and they're called clear cells, and those are the islands or the islets of Langerhans, because it was Langerhans from the previous slide who discovered them. And here's a picture of the islets of Langerhans under a microscope and they've been stained. And here's the digestive cells. Whoops. And here is the island. And I always had to kind of squint to see this sort of thing on a microscope slide. I was never good at microscope slides. And but I think you can make that out. Okay, so what does the pancreas do? Well, now we're come forward a little bit. It's about 20 years later, and everybody knew we had a pancreas, and everybody knew we had these cells in the pancreas, but nobody knew what they did. And so here it is. The names are what really I like about this story. This is Joseph van Meering and Oskar Minkowski. These just flow off the tongue beautifully, and they were at the University of Strasbourg in Austria, I guess. And they took the pancreas out of a dog to see what it did. I mean, this is, what does it do? I don't know. Break it and see what stops working. And that's what they did. So what did they observe? And what they observed was ants. Ants. Yeah, well, it turns out when you take the pancreas out of a dog, just like a child with diabetes, they start making huge amounts of urine. It's one of the three cardinal symptoms of out-of-control diabetes. Polyuria, making lots of urine, polyphagia, being hungry all the time, and so eating, polyphagia is eating, and polydipsia, being very thirsty and drinking all the time. And that's because you're losing all that water that you're urinating out. So what did they observe? Well, they observed that the dogs were making a lot of urine, and their lab tech, the guy who kept the cages clean, he said, "Professors, I don't understand. All of a sudden, there's ants everywhere in the dog room. And why are there suddenly ants in the dog room?" Anybody have an idea?
Is it because the urine is sweet, like the
Yes,
glucose coming out?
exactly. Very good. So these poor dogs were suddenly he gave them diabetes by taking out the pancreas. They're urinating, and their urine they're making a lot of urine, and it's full of a lot of sugar, and it's attracting ants. And so they figured that out. And that was the first thought about what the pancreas might do. It had something to do with diabetes. Now we're in 1900. Whoa, why does this thing keep doing that? All righty. 1900, student, another medical student, and he was looking at the same tissues that Langerhans had looked at 30 years earlier, but he's looking at it now with new technology. And this is a theme in all science. You go back and you look at the same thing that we always looked at, but you've got a new technology to look at it. So we're taking pictures of the moon, but now we're taking with a better telescope. We're taking pictures of stars that are, tiny little pinpricks, but with the James Webb telescope, we can get this tremendously detailed picture, and you learn a lot more. And the same happens in biology. And what he noticed was when he looked at the cadavers of people who died of diabetes, that the islets of Langerhans were gone, that the rest of the pancreas looked pretty normal, but he lost the islets of Langerhans. And so he wrote that down. He said, I don't know what's going on, but when you have diabetes, it looks like it's got something to do with the islets of Langerhans in your pancreas. Now, remember, we still weren't clear what the islets did, but anyway, he went on. Here's a picture of him. I think this is his graduating class in 1900. And there he is with the white circle around him. He gave up science and became a medical school dean, which is kind of sad, but happens a lot. Okay, now it's 1906. George Ludwig Sulzer, the names, I just love the names. He was actually figured out, well, if the diabetics, it's in their pancreas is let's give them a fresh pancreas. And so he was taking these dogs and giving them injections of pancreas from another dog. And by injections of pancreas, I mean he would get a pancreas from the butcher and he'd chop it up and slurry it up and shoot it with a hypodermic right into the other dog. And it kind of worked a little bit. And so he tried it on a patient in Berlin in 1906, and it worked for a while, but the patient had terrible side effects and died because they ran out of the extract and they just couldn't make enough to keep the guy alive, the patient, a young child. Sulzer continued to work on diabetes for years, but he never got any further than that. And eventually, his lab was converted to military purposes during World War I by the German Reich. So that's another story. War interferes. We make a lot of scientific progress preparing for war and waging wars, and it also destroys scientific progress. So this guy was pretty close to curing diabetes, but didn't make it. Okay, 1910, a couple of years later. Now this is in England now, and we're talking about Edward Albert Sharpie Schaefer. Okay, now the great thing about Professor Sharpie Schaefer is he is named after not one but two writing instruments. Okay, this is I don't know anybody else who's named after two writing. I wish he had a middle name of Cross, or I don't know, Ticonderoga, something. So, okay, he's a physiologist, and he knew about adrenaline. In fact, he had discovered adrenaline, the hormone not from your pancreas, from the glands above your kidneys called the adrenal glands, because they are above the kidney, adrenal. And he said, oh, those glands make a hormone, and here it is. I found it. I got it out. I extracted it. And since it's coming from the adrenal glands, I'm going to call it adrenaline. Okay, you discovered it. You're entitled to name it. That's great. And he said, I predict that because there is a hormone for diabetes, and we're pretty sure it's coming from the islets of Langerhans or the insula of Langerhans, because insula is another word for island, like insulated on an island by yourself. He said, there is such a hormone, insulin. Now, he never found the hormone. This guy named something without discovering it. So earlier we had Langerhans who named it, but gave it the wrong reason. This guy he gave it the right reason, but he never discovered it. These guys were just so creative with their science. Now his name was Schaefer, but in England in the World War I, having a German name was not good for you. There was a lot of discrimination, and I mean they were at war with Germany, so that would be like, well, it would be like if my name were Osama bin Laden, I would probably want to change it. So he changed his name. Um, his name was Schaefer, so he added his thesis advisor's name, who was Professor Sharpie. So that's how he got to be Sharper Shafee or Sharpie Schaefer. And I think this is a great practice. I tried to get my graduate students to change their name, to put my name on them, but none of them have taken me up on it. Okay, then 1911. Now we're at the University of Chicago. University of Chicago is a great research institution, and they brought us such wonderful things as trickle-down economics and the first nuclear bomb research. And they almost invented insulin because this guy Scott at the University of Chicago made a better extract and was able to really help dogs a little bit, but he couldn't get his research director, his boss, to see the value, and it was shut down. And he was this close to discovering it. Okay, 1915, Rockefeller University. He did the same thing. Israel Kleiner. He had it, and he was just needed to purify it a little better. And World War I broke out. He gave up his research, and he became a dean. We got two failed diabetes researchers became deans. Okay, how do you really get at the insulin? Well, you could feed the patient's fresh pancreas, which, by the way, I mean, pancreas is completely edible, and it's a delicacy in some cultures, sometimes called sweetbreads. But the digestive enzymes that the pancreas secretes actually eat up the pancreas if you eat it. It's a real mystery why the pancreas doesn't dissolve itself. But if you put some pancreas in a stomach and into the intestine, it gets destroyed. So and the insulin gets damaged. So what we needed to know then was how to get the insulin out of the pancreas before it had been destroyed. Okay, this is the true hero of the story, and you can tell because look at that photograph with the soft lighting and his face to the light and the glints, the far. I mean, this guy is clearly a hero. He was an orthopedic surgeon, and as an internist, I never got along with the orthopedic surgeons. I mean, they go to work with hammers and chisels, and I find that's not my idea of how to do healthcare. But well, if you need one, you need one real bad. Right, he opened his practice in London, Ontario. The first month, nobody came. He was getting nervous. Finally, a guy comes in. He was a soldier on leave. He said, and Canada, it was during Prohibition. Canada was dry. You couldn't get liquor. Hey, Doc, can you get me a prescription for some liquor? So I'm going to throw a party for my friends. And nowadays we don't get that, but we get exactly that for I need the opioids, for my pain. And some of these people are faking it and they're using it to basically to party. So Banting did not like this. He said, "This is not a way I want to live. I'm going to go into science." So and he had this little. He says, "It's been my habit for years to keep a book with a black cover, And I just write down all my research ideas. That's what he wrote 20 years later. And this is the actual page of the book from October 1919 or 1920. And what he did is he went to a med school dean and he says, "Look, I'm not enjoying practice. Can I teach some medicine?" No, come on, you have to be a genius like me to do it. And Bennington went to some other professors and they didn't let him in either. And finally, he found one guy who said, "Look, I've been assigned the worst course in medical school, carbohydrate metabolism. It is so dreary." And it is dreary. It's a terrible topic. And he said, "So if you can give my lecture on that." And so Banting got all excited. He started reading, went to the library, and he read an article by a guy named Moses Barron saying that when he tied off the pancreatic duct with surgical sutures, with a ligature, it's called, the cells of the pancreas degenerated, but the islet of Langerhans remains intact. So the digestive cells get destroyed, but the islet can still make insulin. And this intrigued Banting. And at 2 o'clock in the morning, he wakes up and he writes down these words in his book: diabetes, which he misspelled. Ligate the pancreatic ducts of dogs. Keep the dogs alive until the acini, the digestive cells, degenerate, leaving islets. Try to isolate the internal secretion of these to relieve glycosuria, which is diabetes. And he wrote that down, and that's the idea. And it's brilliant. Okay, so he talked with a bunch of guys, including this fella, J.J.R. McLeod, who was the big professor of physiology at and the associate dean at Toronto, University of Toronto. He had once been a professor of physiology at Western Reserve University, so we know he was very, very good. I just happened to mention that's my alma mater. That's how I know how great he was. But he, you know, he didn't want to stay in Toronto for the summer. He liked to go fly fishing in Scotland. So he said, "Okay, you can use my lab." And I got 10 dogs in the kennel, and you could do your research on them. Oh, and by the way, I'll throw in a pair of medical students because they're cheap. Okay. So he got these two students, Charlie Best and Clark Noble, to use as lab assistants, and he went off to fish in Scotland. This is not a picture of him. I couldn't find a picture of him with a fishing rod, but it is fly fishing. Here's Noble and Clark. And they were best buddies. They played baseball together for the Georgetown, Ontario baseball team, 1920. Noble played first base and Best played catcher. And I'm pretty sure the one on the right with the catcher's mitt, therefore, must be Charlie Best. So Banting required only one assistant. So they flipped a coin. He said Best lost the coin cost. So he had to take the first month. And Banting took the second month and he got a month off. However, it turned out to be really difficult to teach a medical student how to do surgery on a dog. It took him all a month. And at the end of the month, Best was just barely competent. And so Banting said, "I don't want you to join the lab." The lab was so tiny, there wasn't room for three of them. So Noble was off the team. Okay, Banting's method was to tie a ligature around the pancreatic duct. So the pancreatic duct is this thing through here. So he opens up the dog. He opens up the pancreas with a knife, threads a needle and thread around these ducts here, and ties them off. sews up the dog, and hopes the dog has survived this surgery. They did have anesthesia a little bit, so that was okay. After several weeks, the pancreatic digestive cells had died off and been absorbed, but it left piles of islet cells. And so they then they reopened the dog, take out the islet cells, essentially put them in a blender, and take out what they're now calling iletin, because they called them the islets, not the insulas. But too late. McLeod had already named it insulin, so they lost that. And he went and tested this extract on other dogs that they had taken the pancreas out of. By the way, here's the lab. It's still around. They preserved it up at the University of Toronto. And this is the kind of equipment they did the whole thing in. Doesn't look much, these labs look a little different now. But, okay, here's Banding and Best. And this is the dog. Probably, I think the dog was named Daisy. Some reports said the dog was named Alpha. And they kept this dog. This dog has no pancreas. They had taken out the dog's pancreas, and they kept this dog alive for months. Now, the pancreas is a vital organ. You can't live without a pancreas unless you get shots of insulin. And they gave it a crude extract that they had prepared and kept the dog alive. And the dog's kind of cute, I think. It's a nice dog. So Daisy. Okay, the next slide is gross. So it's gonna be really ugly. So if you're faint of heart, you should leave the profession now and just turn off your computer. Okay, Banting and Best presented the results to McLeod, and he came back and he noticed there were some problems, and he suggested some additional experiments. He gave them more dogs, he gave them better equipment, and he gave them some good ideas. And he put Banting on the payroll of the university, so things were looking up for him. And the second round of experiments were successful. However, they were having trouble with the pancreas of of dogs, because it took so long to extract all the insulin. And so Banting had another brilliant idea. He said, let's use an animal that has not yet developed all its digestive glands. And the answer to that is a fetal calf. So here's a fetal calf, and they operated on it and took out its pancreas. I just noticed there's flies in this picture. Wow, that really is gross. So, and it worked pretty well. So they could now make enough of this stuff, but it was still junky. It wasn't pure. So they brought in a biochemist, a guy named James Collop, and within a month, they had a more pure insulin. Okay, here is the first patient. His name is Leonard Thompson. He was 14 years old, he had diabetes, and he was lying in Toronto General Hospital on a death ward. And they went in and they gave him a shot of insulin. And he immediately got a terrific allergic reaction and almost died right there and then. And everybody went home and changed their pants, and then worked for the next 12 days, day and night, and really worked to improve their pancreas extract from fetal ox. And a second dose was injected on January 23rd. This was completely successful. No obvious side effects, but there was no more sugar in his urine, and he felt better. Here is a ward at a hospital in the 1920s. This is what they look like. So these are right out of Charles Dickens, right? And there's 50 patients on the ward, and they're all dying. They're all kids dying of diabetes. and the family members are at the bedside, and there's grieving and pulling of hair out. It's horrible. In one of the most dramatic moments in the history of medicine, Banting, Best, and Collop mixed up a big batch of their new purified insulin and went around the entire ward and gave every kid an injection. And by the time they got to the last kid around the ward, the first kid woke up from his coma. And they all did. I still get goosebumps thinking about this. These guys worked with dogs and cows, fetal calves, across the street in a laboratory and they did their little surgery, their veterinary surgery, and they massaged this and they ground up that and did this magic and took a bucket of it across the street, injected it into these kids on the edge of death, and brought them all back. It's absolutely amazing. It is a scene from a movie. Here's a diabetic kid before it, 4 months after insulin, and here she is starving to death. And then in the right, after 4 months of insulin, she looks like a normal kid. Okay. And Best and Collop made a patent for insulin, which they gave to the University of Toronto for $1, and they required so that insulin could be made for without patent restrictions. It could be made cheap for anybody. You didn't have to pay Banting and Best $20,000 a year for your insulin. And the Nobel Prize for Medicine was awarded to Banting and MacLeod because they were the senior authors on the paper, 1923. But Banting felt Best really should have gotten part of the prize, so he split his prize, and therefore MacLeod, who was kind of pissed at Banting over something, gave his share to Collop. But nevertheless, Collop and MacLeod, you never hear about them. It's always Banting and Best. And they got the Nobel Prize in 23. Okay, so that's how we got diabetes and insulin, and it was the greatest breakthrough in medicine to that day, and one of the 2 or 3 great medical breakthroughs ever. Today, kids with diabetes routinely live into adulthood. Over 95% of the patients alive with diabetes are now adults, and they have the diabetes of adulthood, which we didn't even know about back then. Diabetics started living longer, but you can't cure diabetes with insulin. So now, Leonard Thompson at 14, he was alive and thriving, but over the next 20, 30, 40 years, it turns out that diabetes does other things. Notably, it gives you vascular disease, blood vessel disease, and you get heart attacks, strokes, amputations, kidney failure. So insulin wiped out one disease, the acute fatal pediatric diabetes, but it kind of caused or enabled a whole nother chronic diabetes. There was never chronic diabetes before. Now we have almost all diabetes is chronic. Okay, how do you make this stuff? It used to be made from animal pancreases, as we talked about, but nobody makes it that way anymore. Since 2006, all insulins made in the US are synthetic human insulins, or their analogs. A biosynthetic human insulin is manufactured using genetic engineering techniques with recombinant DNA, and they don't actually make it. It's not human. It's the human recipe, the DNA sequence for human insulin, but it's made in gigantic vats of E. coli. It's actually bacterial insulin. The manufacturers say that this process reduces impurities, but there's no evidence to support that. The porcine or bovine pig or calf insulin works just fine, thank you. Here is the vat that they used to make the insulin in. What happened to cheap insulin? Well, it's now extremely expensive to get insulin. It used to be a few dollars a year. When I was in training, when I started my career back in the 80s, people would sometimes have to spend $10 a month on their insulin. That would be, someone who needed a lot of insulin. Now, I don't think anybody can get insulin in the US for less than a couple of $100 a month. It is, and that's, and it's a generic drug. Well, except you can't get generic insulin anymore. The patents have expired on all the formulations. They're new, they got patented, but the patents have expired, but there's no generics because you have to come up, the generic has to be identical to the original product if you want to get it licensed. And simple molecules like penicillin, you can prove with simple chemical studies that you've made the same molecule. But these large biological molecules like insulin, they can't be proven, especially since the FDA has never published standards on how you would know that you proved your new insulin is identical to the old one. And therefore, there's essentially no way to get a license for generic insulin. And by the way, the biotechnology lobbying group, basically the drug companies, spend a lot of money taking care of congressmen to make sure that no one ever authorizes the FDA to actually allow generic insulins. So let's talk about, I got a little bit more. If you guys have questions on what we've heard so far, I would be happy to take them, and then we can talk about modern problems with insulin. Or not. You don't have to ask me any questions. Of course you have to ask me questions.
I have a quick question.
Yes.
I know you talked about a lot about type 1 diabetes. Can you explain the difference between type 1 and type 2?
Yes, 2 is much bigger than 1. It's twice as big. Oh, type 1 diabetes. Okay, so type 1 diabetes is absolutely insulin deficient case. The pancreas has burnt out and the islet cells are making no insulin. And this can happen at any time, but almost always happens in kids. We don't exactly know why it happens, but when it does, you have to get insulin on board or the patient dies in days to weeks. So that's type 1 diabetes. Type 2 diabetes is it's a lot different. It's the patient has a pancreas that's making plenty of insulin, but for some mysterious reason, the cells in their muscles and bones and nerves and blood vessels and brain and fat doesn't respond to their insulin as well as it used to. They get resistant to insulin. Something makes the peripheral cells, they're called, not the pancreatic cells, stop dealing with insulin well. It's a halfway measure. You can be a little bit type 2 diabetic where your sugars, you're short of insulin, or your body thinks you're not getting enough insulin because it doesn't recognize a lot of the insulin. So your body cranks up your pancreas to produce more and more insulin. And you're trying to overcome your insulin resistance by flooding yourself with insulin. So type 2 diabetics actually have hyperinsulin levels, elevated insulin levels. In the end, both of them produce high blood sugar, one because there's no insulin, and two because it's resistant to the insulin. And the high blood sugar causes most of the later complications: nerve damage, blood vessel damage, kidney failure, etc. Did that answer the question?
Yes, it did. And Latavia, I hope I'm saying your name right, said, why is insulin so expensive now in comparison to how it was years ago? I think you answered that a little bit, but
I
maybe
tried to. The drug companies have figured out a way to keep it patented and restricted so that no one else can enter the market. There's no competition. They keep the prices up. These are the people who say capitalism is good because of competition, but they don't allow it in their field. Does that make sense, Lita?
Yeah, it makes sense. Thank you.
Okay. Any more questions? As
Yes,
far as I know, it's
actually, I
just
had a
it's just the
question.
four of us. So
Actually, I had a question.
who's that?
Manasvi.
Hi, Manosby.
Hi. So, since manufacturers claim that biosynthetic insulin has fewer impurities,
Mhm.
um, I was wondering, do we actually see the measurable benefits in patient outcomes, or is it more of like a manufacturing claim than a reality?
It's a manufacturing claim with no evidence that we know of. It's theoretically plausible, but impurities are not a major problem in standard bovine insulin. So now I will say the new insulins have other advantages. Notably, you can make them so they're long acting and you don't have to take frequent shots. And
Uh-huh.
that is a huge advantage. But those insulins have been around for a very long time and they're off patent, but there's no competition for them either.
Okay, that makes sense. Thank you.
Okay, what are the physiologic effects of the drug? Um, how can these effects be abused? And who's likely to take advantage of these effects? And what does insulin do to your weight, to your body weight?
Weight loss.
Insulin actually makes you gain weight. It's one of the growth
Oh,
hormones. And in
I
fact,
see.
type 2 diabetics, if they tend to be overweight, if they can get their weight down, they often discover that their diabetes gets easier to manage because the
Interesting.
because they're if they're less if you're less obesity seems to be part of the story about why people are insulin resistant in type 2 diabetes. So if you can reduce obesity, you're less insulin resistant, you have less insulin around, and you don't gain weight as much. And diabetics who take insulin gain weight from the drug itself. And it's a different mechanism than what was causing the kids to lose weight when they had no insulin. That was because they couldn't metabolize their sugar that they ate, and it wasn't going into their muscles and bones and fat cells, and it was just going out in the urine. In type 2 diabetes, the sugar sticks around and gets deposited and converted to fat. So if you are a diabetic and you don't like your body weight, cut back on your insulin a little bit. Okay. Who's gonna do that? Play Russian roulette with their life so that they can get into a smaller clothing size. Any ideas?
Models.
Yeah, teenage girls, adolescents, especially girls who are, often very, very worried about the shape of their body. So, what do the tissues do when they have extra insulin? It's a growth hormone, right? So what happens when you give the growth hormone insulin to somebody? They get bigger. Notably, you can increase your body mass. And if you're doing a lot of exercise, it won't necessarily be fat. So who likes this?
Bodybuilders.
Guys, like this and the weightlifting and stuff.
Exactly, bodybuilders. Okay, another question about insulin. What if you take a lot more insulin than you're supposed to? What happens? I'm talking about you usually take 20 units, and by accident you take 500 units. Overdose. What's an insulin overdose? What happens? I'll tell you, you don't get high from it. So
People can go into coma.
why is that? That's exactly right. Why? What is insulin? Why do you take the insulin? To get your blood sugar down.
Right. Because
So
they have too much blood,
go ahead.
too much sugar in their body.
Well, that's why you take the insulin. If you take too much insulin,
Right.
what happens to your blood sugar?
Does it
It
drop?
It's too low.
It's
Yeah,
too
it's
low.
too low.
What happens when you have too low blood sugar?
It can lead to seizures and irreversible brain damage.
Exactly. Your brain is it really likes sugar. It lives on sugar. And if you don't have enough blood sugar, your brain, you get stupid, and then you get comatose, stupid in the technical term, like in a stupor, and you get comatose and you die. And insulin overdose is well, so who wants to do that? Abby says nobody, but that's not true.
Maybe someone suicidal.
Well, maybe, but I've never seen a case of that. It might be, and it would be hard to know, but murder.
Hmm?
So insulin has been used several times to murder people. Who would use insulin to murder somebody, and who would they murder? Come on, you guys watch
Like
crime.
a loved one for the
A loved
insurance
one,
policy.
exactly. So this is to kill your spouse, and who would do it? Who's the murderer?
The spouse, typically.
Yeah, but what type of person? I mean, my spouse isn't going to do it to me. She doesn't know anything about it.
The doctor?
A
Or like
doctor.
someone.
This is doctors killing their wives. There's been several reports of it. So far, I haven't found a doctor killing their husband yet, but it might turn up sooner or later. I'm sure nurses have also done it. Okay, that's the talk. That's me with my double bass. And I would be happy to take any questions that you like.
We have a couple more questions, and I'm hopeful that other people will also ask questions. Grace Park asked, would you say that one of the best ways to prevent type 1 and type 2 diabetes is by eating healthy and exercising?
No, no. Type 2 diabetes is definitely preventable with, well, it's as preventable as weight control, which is super difficult. Before the GLP-1 drugs, the only treatment for obesity that was effective was surgery. So, it was, but if you can keep your weight down and get exercise, you're much less prone to develop type 2 diabetes. Not completely protected, but a lot less likely to get it. Type 1 diabetes has nothing to do with diet. We don't know why. It's probably some immune disease, a reaction to some sort of insult, possibly in the womb, that manifests itself as eventually the pancreas islet cells die. There's some theory that it was a virus, but we've never been able to find the virus, and it's a major mystery. So no, you cannot prevent type 1 diabetes, but you can probably prevent type 2 diabetes. And if you can't prevent it, you can mitigate it a lot with diet and exercise. And frankly, even if you don't lose weight, the diet and exercise are good for your blood sugar, and they're good for you even if you're not a diabetic. They're good for almost everything. So diet and exercise is the way to go. And that's easy for me to say because I hate diet and exercise.
Thank
But
you.
got to do. Any other questions?
Yeah, another question from Miriam. She said, hypothetically, in the future, could biohacking or genetic modification offer new approaches to regulating insulin?
Sure, sure, theoretically. I don't know. The best thing we have now are a couple of new insulin variations that we can give. And the problem for the last 100 years since the invention of insulin was knowing exactly how much to give and when. Because the correct answer is when your blood sugar goes up a little bit, you should give a little bit of insulin. And you should check it every couple of seconds because that's what your pancreas is doing. Right now, your pancreas is adjusting your insulin level, bloop, 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 unless you're a type 1 diabetic, in which case your pancreas isn't doing nothing. So what we've had for most of my career was, well, you could check the urine, which runs a couple of hours behind the blood, or you could check the blood. Later, we got home blood testing. You could check the blood test and give yourself a dose of insulin now, but in 5 minutes, your blood glucose will be different, and you'll need a different level of it. And so, some people were taking insulin 6, 8, 10 times a day to try to get their blood sugars from never going too high, never going too low. It's exceedingly difficult. So now we use a computer. We put a glucose sensor. They can actually inject it under your skin, and it got a little Bluetooth chip, sends a note to your insulin pump that you're wearing on your belt, and it doses your insulin spot on to your current blood sugar. And that works better, not perfect.
Yeah. I don't know how to pronounce your name, so I might butcher it, but Laxon asked, I wonder what aspects we can still improve on if insulin through research and how we can use AI to potentially develop in this field. Do you see
Well,
AI taking over?
I don't know about AI. So far, I've been there's been some AI has been helpful in some areas. I don't know about insulin research. The things about diabetes that can be improved are figuring out ways to get tighter control of blood sugar so it doesn't go up and doesn't go down. It stays in the normal range, in spite of whether you eat or exercise we've probably pushed the timing of insulin, long acting, short acting, about as far as we can, I suspect. But drugs that stimulate the peripheral tissue to make better use of insulin, we have a few, notably metformin, which is quite a nice drug. But more drugs to do that would be very useful. And the GLP-1 drugs, which are spectacular wonder drugs, they're probably going to turn out to be as wonderful as insulin. But right now they are so expensive that you can't. Many people cannot afford them, and so I think the next breakthrough in diabetes care is going to be breaking the market for GLPs. And that would require, in the US, that would require a change in government policy that doesn't seem likely in the next year or two. The part about this story that I am really interested in is not so much the diabetes and the insulin. The insulin's interesting. The diabetes is really interesting. It's important stuff. But the way these people figured out what was going on, building step by step on top of, one guy figured out that it was in the pancreas, and the other guy figured out, and not only that, it's in this part of the pancreas. And someone else figured out, oh, when you take that part out, this is what happens. And someone else figured out. So it must be, they each were building on a little bit that someone else figured out. And it's that, and they did it, and it was all pretty logical. They were and it was kind of elegant. And it didn't take that long, to be honest. Most of the story I told you was over the course of about 50 years. And it's, and it was the first time anybody had ever done that. Right? This is the first time anybody had ever invented a biologic to give someone. I mean, really. So that's the part that I was always intrigued in. How do you do science? How do you make the world better? And you've got the physiology part, the basic science, the chemistry of insulin and the anatomy of the pancreas and the chemistry. And then you've also got the making a product out of that, right? So getting the insulin out, getting it into a vial, inventing the hypodermic syringe. We didn't talk about that, but that was a 19th century breakthrough. The coming up with a way to produce insulin at scale. Does anybody know who did that and what his profession was? His name is still on TV almost every day. His name was Eli Lilly, and he was a butcher. And he heard about Banting and Best, and he said, well, I got a lot of pigs' pancreases, fellas. Come and get them. And he got in the business of wholesaling pig pancreas. And then he just said, well, cut out the middleman. And he started making the insulin himself. And he figured out how to scale it up. And that was essential for getting this, this brilliant cure. 50 kids in Toronto, that's swell. But millions of people use insulin. So there's that whole thing has to be worked out. And then the crazy economics and why don't we have cheap insulins and all of these, and then all of these weird side effects of insulin, like adolescents starving themselves with chemicals so they can look the way they want to look, and risking kids show up in the emergency room of every hospital in the country from either withholding insulin or overdosing their insulin to control their body weight. All the time. It is every pediatrician in the world sees this all the time. And it's, we don't have a good solution to it. So there's this whole spectrum of problems need to be addressed. And we also need bedside doctors to figure out how much insulin to give and what other medicines to give. And diabetes, there's a pile of other medicines available now. And there's 1,000,001 things we can do and need to do. And it's complex and it's requires, grasp of medicine and arithmetic and, economic. You need to be wise and technically savvy to be good at it. And that's the part where you're dealing with one patient at a time. But we also need smart people, doctors and other scientists to do all the background work so that we get things like insulin delivered that we can deliver. So, and if AI is these guys did it with microscopes and scalpels and colored dyes to stain the tissue. Maybe the next batch we build with AI, but you got to know a little bit about AI to do it, right? So the next step the next step is probably going to be just like the last step. Take new technological tools, computers, AI, lasers, whatever it is, and start experimenting with them until it talks to you and tells you something like, oh, look, there's ants on the floor. What does that mean? It tells you, we didn't expect that. And then you start to get understanding. So that's the story I really care about. Insulin is cool, but not like that.
Love it. Our next question is Latavia again, and she said, could diabetes also be connected to genetics?
Sure, absolutely. Type 2 definitely runs in families. Type 1, we don't think there's any genetics. We do think there's some evidence that you get clusters of type 1 diabetics. Not that the cases show up at the same place and time, like a cluster of COVID, say, but it is among people who were in the same place and time when they were conceived. It's really wacky. It's the only disease I've ever heard where that pattern has appeared, and I've never heard it explained. So presumably there is something affecting the fetus early in development that is environmental. Might be maybe kind of the causative factor in type 1 diabetes, but not been proven. Type 2 diabetes is definitely runs in families. It may be partly genetic, but it's certainly environmental. You learn to eat and move and work from your family, and the lifestyle things definitely contribute. So I learned to overeat from my mother, and she was a good teacher, and it sets me up for health problems, and that's true of everybody in the world. I used to say everybody in America, but we've now proven it's everyone in the world. Any other? What else you got?
We got a few. Someone said that might be a silly question, but why does animal extracted insulin not trigger an allergic reaction? I think they mean more rejection, but
yeah, it could be an allergic reaction, I guess, but or a rejection. And the answer is that insulin is remarkably similar across all species. Every mammal, fish, birds, and insects, you can get insulin out of a fly. They're species to species. The insulin is a little bit different. I forget how many amino acids are in insulin. It's a huge number. Like a handful of them are different between a cow and a pig and a human and a dog and an ox and it's a little more different in fish, but they're pretty similar. And it's so similar that your body does not usually recognize bovine insulin as foreign. Sometimes it does. And then in the old days, we'd say, well, you're reacting to bovine, so we're going to give you porcine, and that worked. Or you're reacting to porcine, we'll give you the bovine. And I think you could also get sheep insulin if you really got into trouble. But the human insulin or the E. coli insulin that the E. coli make, is exactly the same sequence without any minor variations at all. So that's a theoretical advantage, but not one that I would say is worth the huge price for most people.
that makes sense. Langshan, messed up his name, but I'm gonna get it this time. Asked, why do some family members have a history of diabetes, and how does that genetic inheritance work?
Well, I think I was answering that. There's a gene. There's at least there's a slew of genes that contribute to the risk for diabetes, and also you inherit non-genetically. You inherit a lifestyle from your family, and that makes, for instance, if your family is vegetarian, your incidence, and vegetarians eat better. They tend to have a lower rate of diabetes and obesity.
Makes sense. Someone asked, how can patients go from diabetes 2 to diabetes 1?
It 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 doesn't really happen. It looks like it happens. Eventually, type 2 diabetes, you're making insulin, but your body is resistant to it. So your blood sugar stays up because the cells aren't listening to the insulin signal to, hey, suck up this glucose and do your magic with it. And so the glucose stays high. So your pancreas says, whoa, guys, really suck up this glucose, and it sends out more insulin. And it gets, oh, right. So they start working a little bit, but then they slack off again. And your pancreas is overdriving and overdriving all the time. And it looks like in some cases it can burn out and just lose the ability to make insulin.
Hmm.
But probably not the same mechanism as type 1 diabetes. Not that we know what that mechanism is, but you get a burnout after being hyperinsulin. You become hypoinsulin and eventually zero insulin, and then you basically you got to have a lot of insulin. In the clinic, it kind of doesn't matter because these are insulin resistant patients. You tend to already be giving them a lot of insulin. So you might run a blood test and discover, oh my God, you have no insulin at all, but it doesn't matter because we're giving you insulin.
Another person asked, agony, asked about islet transplantation, or if that could be.
I
don't know.
I haven't looked into this in a while. So the answer is I don't know the latest. There's been lots and lots of trials. People really, I mean, that would be lovely. It would really only work for type 1.
Okay.
Right? Where the islets are gone. If you can give them new islets and it'll stick, great. And if they stick and grow and do their magic, then you won't need insulin anymore. Exogenous insulin, you'll have your own. Type 2, most type 2 diabetics have got plenty of islet cells. They got more than their share. They're just not, they're resistant to the insulin, so they don't need an islet transplant.
One of the other questions is, I've heard of diabetes with both type 1 and type 2. What causes that? I think we kind of already went over that, but do you want to give a brief little
Well,
run through?
I mean, is the question what causes people having both?
Yeah.
And my answer is they really don't have both. They have one or the other, and type 2 can sometimes burn out so bad that they lose their insulin and it looks like type 1, but it's not really type 1. And nobody cares if it is or not, really, because you still got to treat it the same way.
And then Langshan asked another question. It says, I have another question that when Best and Banting were doing the experiments on dogs and patients, were there established or certain ethical concerns like we do today? If now we have ethical concerns, could we potentially limit future discoveries? And how do you balance ethical concerns and scientific advance in your own research?
Okay, it's a simple question with a 4-year degree in response to it. So the short answer is no. There were no IRBs, institutional review boards, no ethics panels. They technically, if you inject somebody with something without their permission, that's assault and battery. However, doctors were never treated as criminals for that. And I would like to think that Banting told the parents what he was up to, but I'm not convinced he did. And on the other side, these kids were going to be dead in a day or two anyway. So it would have been a very strange parent who said no. Um, but I, but that's for this drug in this situation, a drug that a drug that doesn't work so well or has more side effects. You know, you do hate to kill people without at least giving them a chance to get out of the way. Are the ethical constraints, are the ethical parameters a constraint on research? They're a constraint on the efficiency of research. I have never had a research project where it was actually an ethical constraint that prohibited me from doing it. But I did have to, by the time I got into the business, we had informed consent for all stuff, and it got more and more complex over the years. And the requirements for what you were allowed to do and weren't allowed to do got stiffer and stiffer. And it takes more and more of my time to negotiate them. But it was anytime I was halted, it was not really on an ethical reason. It was on a legalistic, but we might get sued if something goes wrong kind of basis. And without a real, no, no, I'm not, I know it's not really wrong. You're not really hurting anybody. But if somebody does get hurt, they could claim it, and then we'd have a big stink on our hands. So we don't want you to do the research. And you have to work around that. And it's a big problem. On the other hand, science has been abused as horribly as any other institution, including poisoning patients or withholding treatments or on and on, doing surgeries, sterilizing. The history of medicine is strewn with abuse. So the ethical procedures are well and good and need to be observed. It's not all cost. There's real benefit to them. Did that answer your question?
I assume so. I mean, Langshan can ask again, but we are running out of time, and I probably have time for. Oh, Langshan actually said yes. I
Thank
do
you.
have time for one last question because we're running a little late. So Tala, you are the last question. And it does say, are younger generations in the US more biologically vulnerable to type 2 diabetes due to the increased exposure to food additives, pesticides, and soil toxins that are banned and regulated in other countries?
Probably not. We've never been able to find the pesticides, toxins, and pollutants or can cause all sorts of problems, but no evidence that they cause diabetes. So the answer to your question is no, but with the possible exception of ultra-processed foods. I'm not sure if it's an additive or itself or the fact that the calories are so dense in junk food that you can eat so much more than you need that it sets you up for overweight and therefore diabetes. And I think the preservatives let them manufacture them that way, but it's not the preservatives themselves that poison you. It's the excess calories. I would like to thank Abby and Latavia for showing me their faces. The rest of you are cowards. And I showed you my face, so That's all. I just wanted to say that.
You wanted to nitpick? I also like to nitpick. Well, I'm going to finish up here. Dr. Littenberg, thank you again so much. I always recommend that everyone writes a little reflection after they finish each session. This accounts for in-person as well. I always recommend even students in person write about a reflection, and you can maybe edit your questions, but some of the questions that we always say that you should include are: what brought you to session today? What are your 3 major takeaways? And what do you want to learn more about? You can always ask these questions to your professors, your teachers, any doctors that you shadow as well. It's always nice to have a question bank loaded and ready for all of the other different live sessions. And we frequently have other live sessions. So you guys can always ask those questions during those times as well. But if you want to make your own questions, I strongly recommend that. Applications to med school do include kind of reflections on what you learned, what you took away from, what were your favorite memories or aspects. So it's always nice to have a book or a journal that has all of these answers already written for you that you can just rework.
That's what I think that's how he got the Nobel Prize. He had his little black book with his questions written down.
Yeah, you can make your own little black book. You could even name it your little black book and say, Dr. Littenberg gave me this idea. We always recommend that you can share your insights on LinkedIn. You can write these reflections on your LinkedIn page or even on your Instagram page. And if you tag us on those, we frequently will share students' reflections on our page as well. So it gives you a little bit of a social network bubble, and you do join a community in the medicine world that is recognized by the AAMC, that maybe even AAMC directors will see this. So I always recommend that you post those, share what you're doing, share what you're up to. The social world and the AI world are taking over, so you definitely need to be more personable, and this is a great way to do that. So don't forget to tag us if you do want to share your thoughts. If you're interested in being a part of our organization, our nonprofit, we do take on volunteers. We have a giant community of volunteers from all around the world. We work with your schedules. It is completely flexible and open to you. You can work 0 hours a week. You can work 1 hour a week. It depends on what you want to do. If you sign up for a project and it's 5 hours a week, then you committed to 5 hours a week. If you don't have a project in the works, then sometimes you don't need to spend more time on that. But that's 100% remote, and we're welcome for you guys. Again, we run completely off donations and partnerships. And so in order for our program to stay free with all of our tech support and our Zooms and our website maintenance and all of that, we do ask for a few dollars if you have a few dollars. And if you don't, you can always share this QR code with your parents, friends, families, teachers. And then if you don't have family, friends, people that will want to donate, you can also donate your time. I always love seeing smiling faces. I see a couple names in the crowd as well. So what you've all been waiting for is, how do you earn your digital certificate? The quiz is—
Hang on 1 second. I put my email in the chat. If you have a question or a follow-up or something, feel free to drop me a line.
I went ahead and did this emoji. So you guys can find that.
Thanks for your attention, everyone. I'll sign off now.
Okay, thank you so much. Have a good one. So for earning your digital certificate, you're just going to go back to the same course page. It will be in the chat as well, that you got this Zoom information from. You just go to that same page and click take this course. If you haven't registered, I don't know how you got on if you didn't register, or you're going to hit continue. Most of you will have continue. You're going to scroll down to the page that says take the quiz. It is 30 minutes. It's 10 questions. They are multiple choice, single answers. Sometimes we have true falses, sometimes we have multiple choice. Those ones are very less prominent. We usually have single choice. It is 70% or higher to pass the quiz. If for some reason you use up both your attempts, because you get 2, and you need something, something happened, your timer wasn't running, the questions didn't show, feel free to email us at info@prehealthshadowing.com, and we are happy to work with you. We can give you an extra try if anything technical happened. These are open indefinitely. You do not need to take them right this second. You could even go to our YouTube channel or our website, watch an old session, take the quiz for that, and get your 2-hour certificate as well for those. So they're open indefinitely. If you don't have the chance right now to take the quiz, you can always take the quiz later on. So that's open to you. If you have any problems with that, let us know. And again, if you missed any part of this session, we do try to have this up within 24 hours, but sometimes it takes about 48 hours. Depends on how well the file downloads, and these are fairly long sessions. So you can visit our YouTube channel when that is up. It should be up in 2 days. I would be surprised if it's not, but just so you guys know, and that's open to everyone, and our YouTube channel will have it up as well. So be sure to catch our sessions every week. We do have one next week and the week after. I would make sure to get on those. Look for what part of medicine that you want to look at and see if those are some interest to you. I recommend everyone go to every session you possibly can, because that always helps with deciding what medical career you want to be. So I just want to say thank you for joining. I'll stay around a little bit longer if you guys have any questions, but feel free to email us at info@prehealthshadowing.com. And I wish you guys all the best. Have a good one.
Thank